Morning. Welcome, everybody. Welcome to the Neurology Case Review session at UKIO. My name is Tilok Das. I am a consultant neuroradiologist in Cambridge, and I will take you this morning through a few cases. We've got about 8 potentially to go through, depending on time, of course, which are brain-related, and conditions that are either more common than you might think. Those are rare, but quite useful to recognize. Some of them are almost pathognomonic. But hopefully, most of all, you'll just enjoy going through the cases. They are all available on via the link on the landing page for this session. The red link that says access the cases will take you to a platform called Paxbin, where you can scroll through the images as you might on when reporting or on a PACSphere. So hopefully that will make it a bit more interesting. And for each case, there will be a set of questions to answer, some polling questions. And if you could come back to the SOPCard platform to answer those, that'd be great. And we'll see how we get on. And at the end of each case, I'll introduce the case. We'll go into Paxbin, and then at the end of each case, there's a short sort of discussion about that case. Okay, so let's get started. So case 1, thank you. Here we go. So case 1 is a 66-year-old male and who's presented with recurrent seizures and cognitive decline. And those watching the recording, this will be the question that I ask. So what is the diagnosis? Great. So I am now going to share my screen and go through the case with you, but if you could head to case 1.1 and have a look at the CT first. There we go, lovely. So on the CT scan, I'll talk you through this in case you don't have access to the cases directly, but I think we'll get more out of it if you can. But on the CT, you can see this hypodensity at the posterior aspect of both cerebral hemispheres. And it looks likely subcortical, so not really affecting the cortex. Maybe there's a bit of cortical swelling, but that's of course quite hard to say. If you head over to the MR, which is done later, on the flare, axial flare. So this is our T2 weighted sequence with suppression of CSF. You can clearly see the signal in the posterior part of the brain. Again, mostly subcortical, but maybe down here in the occipital lobe, there's some cortical involvement. The T1 doesn't reveal much more, but certainly no hyperintensities. And on diffusion weighted imaging, I'd have to adjust the window level here, whoops, a little bit. There we go. There may be some restricted diffusion down there where we have that cortical involvement, which you can see on the ADC, but not very much. Okay. And finally, this is the susceptibility weighted imaging. So in this case, a sequence called SWAN, SWI equivalent, and you can see multiple hypointense lesions in the peripheries of the brain on both sides. So if we head back to the polling questions, for question 1 is, what is the diagnosis? I'll just leave this image up here. Okay. So if we head back to the presentation, please, I'll stop sharing. Go. Okay. So we've got a couple of votes in. Well done, both of you. That's correct. It's cerebral amyloid angiopathy. Oops. And of course, the telltale sign here was the lobar microhemorrhages. But the interesting bit about this case is the T2 confluent T2 hyperintensity, which you don't often see, despite seeing many cases of amyloid angiopathy. So amyloid angiopathy itself tends to affect the elderly with these lobar, cortical, and subcortical microhemorrhages. Let me just check where we are here. I think we'd like to switch back to the presentation, please, James. Thank you. And they confer an increased risk of intracerebral hemorrhage. But what we're seeing in this particular case is a specific phenomenon known as amyloid angiopathy-related inflammation. And so it's thought to be an inflammatory response to the beta amyloid deposits within the blood vessels. So that will also present with seizures, cognitive decline, and encephalopathy. And this confluent white matter change is reasonably typical, but it's quite non-specific on its own. So you really need to be able to see the microhemorrhages to confirm the diagnosis. And the reason it's important to do that, of course, is that the inflammation itself is amenable to treatment. So about 85% of patients with it will improve to a certain extent with steroids or some other immune modulating treatment. Of course, the amyloid angiopathy deposit itself is not so far really treatable. Okay, so this is amyloid angiopathy-related inflammation. We see it probably a few times a year, and helpful to recognize. Okay, so our next case is a 57-year-old female, and she presented with 3 weeks of dysarthria and also change in handwriting. So these are going to be my questions. So what is the diagnosis? And if I start sharing my screen, I'll head over to the case. So this is case 2.1. There we go. Okay. So on the CT scan here, we're seeing some hypodensity around in the left parietal deep white matter. Very subtle, but it's there. And particularly if you look now at the MR in retrospect, there's clearly an abnormality there around the ventricular trigone, so abutting the ventricle, and it's extending into the corpus callosum. Notice that there's sort of oh, sorry. Right. Apologies, everyone. I hadn't been sharing my screen myself, but we're looking at this abnormality in the left parietal deep white matter. And on the flare, you can see it very clearly as well. And notice this very subtle sort of hypo-intense line within the lesion. If you head over to the diffusion-weighted imaging, you can see this thin line of restricted diffusion around the periphery of the lesion, also extending into the corpus callosum. But the important bit here is the post-contrast. And you can see this ring-like enhancement pattern. So the question is, what is the diagnosis here? So I'll let you look for another minute or so, and then we'll head over back to the presentation. And just wait for a couple of votes. If anyone would like to have a guess, or have a vote rather. Great. So this is demyelination. Thank you, whoever voted. You got that absolutely right. And the key feature here is that you've got this broken ring of enhancement. It's not continuous enhancement in the wall of the lesion. So this is known as tumefactive demyelination because it does look a bit like a tumor, has some sort of mass-like properties, but actually no real mass effect. It's thought to be, it's on the spectrum of demyelinating syndromes, but not necessarily directly related to multiple sclerosis. So not all of these patients will go on to develop MS. The important features are the lack of mass effect, although that doesn't in itself help you to differentiate this from, say, an infiltrative glioma, which may not have much mass effect either. But the other one is this open ring enhancement, so this broken ring of enhancement. In this particular case, we're looking at a lesion that's around the corpus callosum. But if you have lesions closer to the gray-white matter junction, the lack of enhancement tends to be on the gray matter side of the lesion. If you were to do perfusion imaging for these kinds of lesions, they'd have reduced perfusion, unlike many tumors. Just to show you the differentials here, we've got GBM, of course, so that would be one of the main differentials with that peripheral enhancement, again, necrosis in the center. But notice here, and there is also restricted diffusion, which is what this yellow arrow is pointing at on the ADC map. But here you've got an almost complete ring of enhancement around the entire tumor, unlike the demyelination. CNS lymphoma can present with ring-like enhancement, particularly if a patient's immunosuppressed, but often it's sort of more homogeneous enhancement. You, of course, get restricted diffusion within the tumor, but tends, again, to be fairly across the entire tumor, fairly homogeneous. The one other condition I'd like to show you as a potential differential is PML, progressive multifocal leukoencephalopathy. We see this in the context of immune suppression, but also now certain antibody treatments for MS itself. And notice in this very striking case, the orange arrows are showing restricted diffusion at the edges of the lesion. And this sort of leading edge, this is also a demyelinating process, although due to an infection by JC virus. This leading edge of restricted diffusion is what is often seen with inflammatory conditions. So in addition to the open ring enhancement that we saw, I think that ring of restricted diffusion is really very helpful with these lesions to at least suggest the possibility that they're demyelinating in some way, including MS or tumefactive demyelination. So tumefactive demyelination, we see such cases a few times a year in terms of pre-op. So, they were planned for surgery because thought to be a MET or a GBM, and it's only at the pre-op planning scan that it's picked up as having reduced in size, for example, since the initial presentation, which helps to confirm the diagnosis. Great. Okay, let's go on to the next case. So this patient, a 69-year-old male, presents with recurrent acute onset left-sided weakness. And the questions for those watching at home are again going to be, what is the diagnosis? Okay, so I will share my screen again. Sorry. Right. So hopefully you should be able to see that now. And we're looking at the moment at case 3.1. And on the CT scan, you can see this large area of hypodensity. Sort of fits with the clinical details of left-sided weakness, and does look like it's in an arterial territory, so in the MCA territory. Head over to the FLAIR. There's hyperintensity in that area involving some cortical, but mainly subcortical involvement. And notice the diffusion-weighted imaging, striking hyperintensity in the same territory. However, if we now look at the T1, not much high signal there. No evidence of hemorrhage at this stage on the susceptibility-weighted imaging. Post-contrast, there is quite avid enhancement, which is mainly cortical, but throughout this lesion. So this patient was referred to our neuro-oncology MDT as a very aggressive brain tumor. I'd like to know what you think. If you head over to the poll for case 3, once you've had a chance to have a look, and I'll give you a few more seconds to vote for an answer. Great, okay, got a few votes coming in. Let's do 10 more seconds. Okay, and if you could head back to the presentation, please. Thank you. So in this case, this is infarction. So that's where the majority of the votes have suggested as well. And indeed, the unenhanced CT scan, the history all fits quite well. But it's that enhancement that's quite striking and can be a bit confusing. The suggestion of PRES, and the location is about right in terms of posterior, but this is much more cortical than you might expect PRES to be, and there was nothing on the contralateral side. So again, PRES, although asymmetric, tends to affect both cerebral hemispheres and is more vasogenic rather than cytotoxic edema, usually, although you could have a bit of both. Okay. So I just wanted to show you this because we do get it often, in tumor MDT, or neuro-oncology MDT, and it's this cortical enhancement that can be a bit confusing. But this is typical enhancement of subacute infarction. So the history should fit with something that's happened actually a few days or maybe a week or two ago, rather than the day before. And this enhancement is thought to be related to a mixture of breakdown of blood-brain barrier, new small blood vessels, and there may be an element of necrosis of the cortex, or what's known as cortical lamina necrosis, although often that also shows as T1 hyperintensity a little bit later. And we didn't see any evidence of hemorrhagic transformation in this particular case on the susceptibility-weighted imaging. But if you did, that would show up on that sequence. The enhancement itself is not directly related to hemorrhage. And the main mimic here is tumor, but as you all saw, this is a typical subacute infarction. It's particularly when the slightly smaller lesions, maybe infarcts in the distal part of the MCA territory, that they can be a bit of an issue. Okay, so let's head to the next case. So this is a patient, 63-year-old male, presents with dizziness, blurred vision, unsteadiness. He's had left arm and hand numbness and tingling. And the question at the time of the scan was, is there a brainstem infarct? And the questions for you are, which of these conditions is the lesion that you're going to see? Okay, so if we head over to case 4, and I will share my screen. Great. Let's just go through the images without saying too much here. We're looking at the flare. Diffusion weighted imaging, unenhanced T1, and a post-contrast T1. You may have spotted a lesion already, but notice that there's no abnormal enhancement here. Probably the flare is the most helpful sequence in this particular case. And I'll just stop on that image. If you'd like to have a vote as to what you think this might be. And we've got an answer in already. So just a few more seconds. So is there some sort of odd tumor, a DNET in this case? Is it just an enlarged perivascular space or vertical Robin space? Is it actually focal cortical dysplasia involving cortex and subcortical white matter? Is it a tumor, a low-grade glioma, and needs follow-up? Or is it a multinodular vacuolated neural node tumor, MVNT? Great, so you've got a few votes in, so look at the answer. And this is an MVNT. So an increasingly recognized entity, and in the 2016 WHO classification, it was recognized as a specific entity of its own, and it's essentially a don't touch lesion. So we need to be able to recognize it so that these patients are not biopsied, because they don't seem to have any clinical consequence. And they're thought to be possibly a sort of hamartomatous lesion, but don't change over time, don't explain this patient's symptoms, certainly, and are unlikely to cause any issues in the future. So they have a fairly typical appearance, and this is this sort of multiple small nodules on T2 or flare just to the cortex in a subcortical location. They are hyperintense, don't suppress on flare, unlike a perivascular space usually. And there's no enhancement, unlike some of the other tumor types, and no mass effect. Most of the described cases are supratentorial, but there are papers now showing case series of infratentorial lesions. So they could happen in both. And this is a very nice review or case series from Toronto, which showed all their experience of these tumors. And indeed, if you look at all the images, most of them do look fairly characteristic. So although you might have some confluent changes closer to the cortex, if you look a bit deeper, a bit further subcortically, you'll almost always see these little nodular dots. So the strategy for these patients is essentially, suggest it so that it's not taken forward in terms of, biopsying and so on. That's unlikely to be the cause of whatever the patient's symptoms might be. And at most, you might want to follow these up. So the case that we saw hadn't changed in about 3 years. And you could do some follow-up imaging over time just to make sure that they're stable, but probably after 1 or 2, you won't need to image any further. So this is MVNT, multivacular neural node tumor, and recognized more often. These are some of the differentials. So we suggested DNET, but that tends to be involved cortex, much more sort of bubbly appearance, which is the typical description. Perivascular space, so that's PVS, which we're showing a large lesion in the basal ganglia in this image, which suppresses on the flare. Focal cortical dysplasia, a bit more difficult to diagnose sometimes, but you often see a bit of blurring of the gray-white matter junction and some subcortical hyperintensity, but it tends to be confluent. You don't get that nodular appearance. Probably the closest differential would be a low-grade glioma. And if you did have more confluent changes, that might be difficult to differentiate between the two. So try and look for that nodularity, otherwise follow up. Great. Okay. Okay, we're already on to case 5. So this is a patient who presents with amnesia and confusion. And the question here is, what should be the initial treatment? So are we going to see something where this patient needs antivirals, antihypertensives, nothing, steroids, or thrombolysis? Okay, so if you head over to case 5, and I will do the same. So go back to Paxman. And initially, you will see a CT scan. James, could we change back to that? Thank you. Great. Okay, again, I'll scroll through this without saying too much, but if you could have a look for yourself too. This is the axial T2. There's a couple of hyperintense foci in the parietal deep white matter, and this is the flare. A few more dots evident. And have a look at the DWI. Just that window that a little bit better for you. Okay, and on diffusion-weighted imaging, you can see maybe a couple of small foci of restricted diffusion. So what do you think we should do for this patient? Okay, let's head back to the presentation, please. And if anyone wants to vote. I think I'll wait for at least one vote to come in. Thank you. So there's a vote for do nothing. Well, treat conservatively. And oh, everyone. Okay, good. So you don't think this is an encephalitis? You don't think it's related to a stroke? So no antihypertensives, something inflammatory, or a stroke that's actually thrombolizable? Great. So hopefully you'll have recognized this as very typical transient global amnesia. And we don't see this very often, of course. Oh, maybe some antihypertensives there also. Okay. So these patients present with a very typical history, and the diagnosis is normally made on the history itself. So they'll have a sudden onset amnesia. They can't remember anything during that time. It tends to last a few hours, certainly less than 24 hours. And whilst they can't remember anything, they're still alert. They haven't lost any sense of personal identity, and so that's different from other sort of causes of confusion, of acute confusion. They're simply just not able to lay down new memories, so they'll never remember this particular episode. And on imaging, if it is done, because it might be done because the history is not that clear, it's mainly to exclude other causes of confusion, but you might see these little tiny punctate foci of restricted diffusion, and they tend to be in the lateral part of the hippocampus. So if you did see this, it's quite reassuring for the patient and the team to confirm that this is transient global amnesia. There's rarely much consequence from that in terms of other conditions, that it doesn't predispose to any other specific conditions. But the differential clinically might be a TIA, but then you might have you should expect other focal neurology, certain types of seizures or epilepsy. But again, the character, I think, of the presentation is often different. So we don't see these cases very much, but of course we do a lot of CT and MR for patients with query TIA, and so occasionally this gets picked up. It would not be visible on CT. Okay, so this is typical transient global amnesia, and the diffusion-weighted imaging is the most helpful here. Okay, case 6. So this is a lady who had a hip fracture 2 weeks previously. She was only she had a total a repair about a day before this presentation, and she then presented with low GCS. Okay. So if you head over to case 6, and there's a number of things that could be going on here, and so these are the conditions that I'm asking you to differentiate between. So if we could share my screen to case 6. And have a look at the CT first. So this is a CT scan done almost very soon after her initial presentation of low GCS post-op. So clearly no hemorrhage. There isn't much mass effect, not a clear-cut stroke, for example. And because there was a concern about infarction or stroke, she also had a CT angiogram. I've just given you a few images here. So again, the carotids look reasonably normal. There's certainly no proximal intracranial artery occlusion. So these are the MCAs, ACAs, and you saw the basilar artery there. Okay, so case 6 also has an MRI attached as a separate study. So you have a look at that now. Now notice on T2, we're seeing a lot more signal change here, very much cortical, and I think you will appreciate that very readily on the flare. Just window that for you. Here we go. So on the flare, you've got lots of T2 hyperintense lesions, mostly cortical, but also subcortical. Sort of has a distribution that looks like it's in a watershed distribution. Okay. T1. You see some hypointensity associated with exactly where you saw the T2 hyperintensity. And then this is the diffusion-weighted image. All of those foci look like they show restricted diffusion, both supratentorially and quite dramatic also infratentorially. We've also got a susceptibility-weighted sequence here. And notice as you scroll through, multiple microhemorrhages. So what do you think is going on here? Take a few more seconds to have a look at the case. I focus particularly on DWI and SWI. and then please vote for your favorite diagnosis. So we did see a case of amyloid angiopathy before. Of course, there's no reason why I would ensure you a second one. Cerebral fat embolism. This is diffuse axonal injury related to her trauma that led to her hip fracture. Is something else going on? Is she septic? And she's got disseminated DIC, intravascular coagulopathy. Actually, have I withheld some of the history and she had a recent cardiac surgery, was put on bypass and therefore ended up with this kind of picture. Great, the first vote is in. Give it a few more seconds. Good, so we've got a bit of a spread in the votes now. Okay, 10 more seconds if anyone wants to have a quick go. All right. So this is actually fairly typical of cerebral fat embolism. Okay, so it is in a watershed distribution. We don't see it again very often, but it has a very typical appearance. So cerebral fat embolism is a rare occurrence, but is typically known to occur after long bone fractures, for example. Tends to occur 1 to 2 days after an event, or tends to be seen or present at that stage. But on imaging, you may not see changes until a few days beyond that. There's a sort of classic triad, which is respiratory distress, so pulmonary changes, neurological impairment, and a petechial rash, particularly around the upper body. But on imaging, what we tend to see is all these multiple foci of restricted diffusion, so sometimes called a starry night pattern or a starfield pattern or starry sky. Might remind you of the Great Hall in Hogwarts Castle and its enchanted roof, and microhemorrhages. And it's really that combination of both DWI changes and SWI changes, microhemorrhages and the restricted diffusion, that helps to confirm a diagnosis of fat embolism. The mechanism isn't entirely clear, but it's one suggestion is that it's mechanical. So when you have your trauma to the bone, fat globules then enter the bloodstream and involve the lung first, get through the lung, and then the rest of the body, including the brain. There's also a chemical hypothesis suggesting that it's actually the inflammatory changes after the trauma that lead to breakdowns of fats into fatty acids that get into the vasculature and cause emboli. What we're seeing on imaging, of course, is an embolic phenomenon. And the differential for this includes sickle cell and thalassemia, but that's also related to fat embolism effectively. But DIC might give you a similar appearance on the SWI, on the susceptibility weighted imaging, multiple microhemorrhages scattered throughout the brain. Of course, you should have some history and hematology to go with that. Diffuse axonal injury can affect similar areas. It tend to be more changes on the SWI than on the DWI. Of course, you'll have the history of trauma, but the microhemorrhages tend to be deep white matter, corpus callosum, brainstem, and a very fairly typical pattern. In the image that we're seeing at the bottom here, bottom right-hand corner of the screen, you can see microhemorrhages in the corpus callosum, and that could have done for diffuse axonal injury. And then other rarer conditions such as vasculitis or if you had multiple hemorrhagic Mets, but I've never really seen it in this way, presented in this way. So this is fat embolism, not very common, but as it turned out, we had 2 cases within 2 weeks of each other, very surprisingly here. Okay, let's head to the next case. Good. So case 7, patient who's known to have an excessive alcohol intake and has presented with a headache. So this case has 2 parts to it. So if you have a look at 7.1 first, and the question is, what do you think is going on here? So I will share my screen. This is a fairly long case, so I'll go through with it. Go through it with you. Thank you. So what you will see first is just a CT scan, plain CT. So you can already see a shallow subdural collections over both convexities here. But is there anything else that concerns you? I'll show you this image and this one here. If you have a vote on that, and then we'll go on to the next part of the case, 7.2. Okay, so you've got a vote anymore? So let me show you what I think so far. So bilateral subdurals, but they're not particularly hyperdense. They don't look acute, and he does have a history. Notice here the sagittal sinus looks a bit unusual. I mean, it's almost an empty delta sign, although normally you'd expect to see an empty delta sign on a post-contrast, on a CT venogram. You might expect venous sinus hyperdensity if you're worried about thrombosis. But as we come down to the posterior fossa, notice this unusual signal again, or density rather, in the right transverse sinus. You may also have seen this apparent basilar hyperdensity. It's a bit more difficult. These are always a bit tricky, and that might need a CTA to confirm. But there is a bit of hyperdensity in the other vessels as well. But I think I would mainly be concerned about this right transverse sinus. And I've got a few votes for venous sinus thrombosis. Okay, so if you head over to case 7.2 now, and the first set of images is a CT venogram. Have a quick look through that. And you will notice the lack or a massive filling defect effectively in the right transverse sinus and in the superior sagittal sinus. The basilar artery looks nicely opacified here. So we've got a venous sinus thrombosis. I have a look at the MR. So here's the axial T2, quite hyper intense within that transverse sinus, although it does look expanded. Again, you've got that signal change in the superior sagittal sinus. But notice here how you've got in the left frontal lobe some cortical swelling. That should also be quite apparent on the flare. So this is a 3D flare. Here you've got your subdurals very nicely seen and the cortical swelling that we saw earlier. Maybe have a look at the signal change within the superior sagittal sinus and this very marked hyperintensity in the right transverse sinus. Here's a sagittal T1 before contrast. And again, notice this hyperintensity within the veins. So have a look at the rest of the scan. I won't say much more. And then if you could vote on what you think the final diagnosis is. So if you could vote with case 7.2, question 7.2. Okay, so I'll just wait a few seconds. Okay, so we had venous sinus thrombosis, as you might have suspected on the CT scan. And the question for 7.2 is exactly the same. Okay, and these are the features that we've already seen. So bilateral subdurals, funny transverse sinus, question mark is sort of equivalent of empty delta sign. But I suppose the question here is, have you looked at the review area? So why has this patient had a venous sinus thrombosis? What's interesting about the thrombosis itself is it looks sort of chronic. There's all this T1 hyperintensity within the clot itself. Also hyperintense on flare, on T2. Not a huge amount of parenchymal change, and that left frontal swelling that we saw did not show restricted diffusion, so it's not an acute infarct at that point. So this all points towards a sort of chronic process. Let me just, if I could share my screen again, James, I'm going to go back to Paxton and have a look at the sagittal flare. And notice that this thrombosis extends all the way down the internal jugular vein here, so sigmoid sinus, internal jugular vein. If you look at the bottom of the film here, there's some unusual T2 hyperintensity around the internal jugular vein. And then if you head back towards midline, notice something going on here at the tongue base. If we look at this on the axials, you'll see what looks like effectively a tongue-based tumor, and probably, although we need a bit sort of more dedicated imaging to confirm, some lymphadenopathy. So we head back to the presentation. Thanks. This was a case of squamous cell carcinoma of the tongue base. Extensive cervical lymphadenopathy led to compression of the jugular vein, and then this chronic venous sinus thrombosis. The patient had very little in terms of neurological sequelae from this, but it was pretty unusual. So I thought this was an interesting case just for remembering that sometimes you can find the ultimate answer on your film, but you have to look at the edges, and it's easy to miss. Okay, so we had both extensive venous sinus thrombosis this left frontal cortical swelling that I mentioned earlier, and you could see the thrombosis on the CTV. Notice also on the CTV that the filling defect is not a big, smooth filling defect, but has lots of areas that have recanalized. So again, points towards a chronic change. On the susceptibility weighted imaging, you could see some changes in the cortical veins, which are the hypointense areas that we're seeing at the edges of the lower image. But at the edge of the film was a tongue-based tumor and the cervical nodal metastases. Okay, great. Okay, so this is our last case. This is a fairly quick one. Patients with metastatic renal cell cancer. They're on immunotherapy for it, and I won't try and pronounce those because I always trip up. And they presented with 3 days of headache and then some hypopituitary type symptoms. So they've had a pituitary MRI, and the question is, what do you think is going on here? If I share my screen again. And you'll notice on the unenhanced image, coronal and sagittal of the pituitary gland. You can see some enlargement of the gland itself. Zoom in there. But that's much clearer to see on the post-contrast imaging. It looks like fairly diffuse enlargement. And if you notice the pituitary stalk, the infundibulum, is also rather thickened. So if you could vote for what you think is going on here. So is this a histiocytosis, like a Langerhans cell histiocytosis, for example? An inflammation of the pituitary gland, a hypophysitis? Is it a MET from their renal cell cancer and they're known to have metastatic disease? Is it something more unusual like sarcoid, just coincidental, or TB, which are classic causes of pituitary stalk thickening and enhancement? I'll just wait a few more seconds for that some votes to come through. So should we say 10 more seconds? Okay, so if we head back to the presentation, please. And this was a pituitary hypophysitis, so an inflammation of the pituitary glands. But it's the appearance itself is not specific, and any of these conditions could show you similar appearance. But it's the history, and they've got renal cell cancer. They're on one of these immune treatments, ipilimumab, and with these fairly novel immune checkpoint inhibitor treatments, we're recognizing more of the related adverse events. So they're called immune-related adverse events. And one of these that's well recognized now and associated specifically with ipilimumab is hypophysitis. So this treatment is used for melanoma and renal cell cancer, and also a few other cancers, including SCC, cutaneous cancers. And we see this with a reasonable frequency. And the treatment is essentially steroids and to stop the ipilimumab, and they usually do fairly well after some time. And of course, temporary replacement of any hormones in the pituitary axis. But the typical appearance is this pituitary and infundibular enlargement, and so it's important to remember to look for that. And the imaging changes can actually precede any symptoms or by obvious biochemical changes. So it's an important review area, particularly for your follow-up of patients with metastatic disease, which we see a lot more with melanoma and renal cell cancer, the surveillance staging scans. So the ipilimumab-associated hypophysitis seen occasionally. Okay, so that was our last case. Thank you, everyone, for taking part. So I've just shown you a few cases of certain conditions that are now readily recognizable, more common than you might think, particularly things like amyloid angiopathy, tumor factor demyelination, and subacute infarct, both of which we've seen in being referred as tumors. And a couple of don't touch lesion, which is with very typical appearances, which is the MVNT, and some rare lesions, but very, very typical appearances again, transient global amnesia and fat embolism, both of which diffusion weighted imaging is really useful. Oh, sorry. And right, hi everybody, I'm back on screen apparently. So and the last couple of cases, which were just to remind us that we need to look at these review areas, so pituitary, especially with these new volumetric scans, which might have a much larger field of view than we used to have. You can pick things up in the suprahyoid neck, for example. Okay, so thank you very much, everyone, for attending and for taking part. I hope you've enjoyed the cases. And for those watching later on, they should still be available for you as long as the site is available. Okay. Thanks, and we'll sign off there.